All right, guys. So my apologies from part one. I did not realize until after I filmed it that it was actually showing you the back side. But since I had already finished, I decided to go ahead and leave it the way that it was. So I apologize for that as far as it showing you the next coming up slide as well. So we'll just move forward. All right. So signs and symptoms of a stroke. Now, again, this could be either type of stroke, and we won't know the difference until we get that CT scan at the hospital. So we could see facial drooping. So one side of the face is actually dropping down as far as if the patient is smiling. It could be sudden weakness or numbness in the face, arm, leg, or one side of the body. It could be decreased or absent movement and sensation on one side of the body. Could be lack of muscle coordination or loss of balance or sudden vision loss, blurred or double vision. Difficulty swallowing, decreased level of responsiveness, speech disorders, difficulty expressing thoughts or inability to use the right words. So that means they know what they want to say, but it's just not coming out correctly. So they have good comprehension, but it's just a speech problem. Could be slurred speech, sudden and severe headache, confusion, dizziness, weakness, combativeness, restlessness, tongue deviation, or coma. So again, it might not be all of these things, and usually it won't be. It will be a handful of these things that you will see with each patient. So textbook signs and symptoms are going to be what we see in the stroke screening, but again, they could be negative on everything that you see in that stroke screening, but maybe have a couple of these other things, and just due to the history, you want to err on the side of caution. Make that phone call, okay? Call medical control and ask them, hey, I got this patient, this is what's going on with them, I'm just not sure, what do you think I should do? And usually if they're having any signs and symptoms, especially if they have a history of strokes or have that history of potential head trauma, or they have a clotting disorder where an ischemic stroke would be more likely, they're going to say err on the side of caution. Go ahead and bring them up here to the stroke center and let's get that CT scan. So looking at left hemisphere versus right hemisphere of the brain. So the left hemisphere is where the stroke is in this left side, and usually it can cause aphasia. Now what I want you to keep in mind is that the opposite side of the brain affects the opposite side of the body. So if it's the left side of the brain that is having the clot or that is having the bleed, it's the right side of the body that you're going to see affected. So if they have weakness on the right side or paralysis on the right side, it's actually the left side of the brain that is experiencing the stroke, and vice versa. So on the right side, that's going to affect the left side of the body. But again, the difference is there also being that with the left side, you might see something is an issue with your speech, whereas on the right side, patients can understand it, but their words may be slurred. These patients also may be oblivious to their problem, so they're not sure. They think everything is fine. They don't see that they're slurring. They don't see that they're having issues with their speech. And so this could cause patients to delay seeking help. So especially if they live alone, it's been a day or two since you've seen this person and now you notice it, they may not know when did the symptoms actually start. And so in that case, we would have an unknown downtime. Now that's going to be really important for us to know whenever we're asking these questions to the patient and we're getting that history. What is the last known normal time? All right, and so we'll get a little bit more into that in the treatment side of things and why that's so important. But knowing when was the last known normal is very important. So let's look at bleeding within the brain. Usually some things to consider here are that the patient are usually going to have a higher blood pressure, and that could be the cause of the bleeding. Okay, so that aneurysm formation or hemorrhagic stroke, the most important or most significant risk factor here is uncontrolled hypertension. Okay, so keeping in mind that that could be what caused the bleeding. But it also might be caused by the bleeding. So as that ICP begins to increase or the intracranial pressure, the body is trying to compensate. So trending this blood pressure is very important, more so than just one abnormal finding. Seeing, is it continuing to increase? That's very important. And a significant drop could occur as the patient conditions worsen, as with any type of shock or significant damage that is happening here within the body. So we're looking at a few things that can mimic a stroke, and this is very important. You'll see some test questions that ask about this as well. Things that you may see those same signs and symptoms, because remember, that was a very broad range of signs and symptoms. So some things that could mimic that would be hypoglycemia or low blood sugar, the postictal state following a seizure, or maybe a subdural or epidural bleeding. And so these pictures here are showing you what those look like, subdural and epidural bleeding. Okay, so we'll talk more about that once we move into like head injuries from traumatic events and things like that. But it is going to be subdural and epidural bleeding is what we're going to see right here in these pictures. Now, looking at seizures, this is a neurologic episode caused by a surge of electrical activity in the brain. So in the United States, it's estimated that 2 to 3 million people have epilepsy. So first we need to understand that seizures can happen for a variety of reasons. One of those is epilepsy. So a person could have epilepsy, and that is what is related to that surge of electrical activity. But people can also have these seizures in response to other things like changes in glucose, changes in temperature, changes in oxygen, which we said the body is very responsive to. So we want to take a look at that as well, that sometimes you're having a seizure, but it doesn't always mean that you have epilepsy. Now, there are several different types of seizures, so we kind of want to break this down, and I also posted a separate video that does a really good job of breaking this down as well, so I encourage you to watch that just as a review once we get done with this. So the generalized or tonic-clonic seizure, this results from abnormal electrical discharges in large areas of the brain, usually involving both hemispheres, and is characterized by unconsciousness and a generalized severe twitching of all muscles. And so those are the two key factors there, is that the patient is unconscious and they're having twitching of all muscles. And you'll see where the difference lies here in just a few minutes. Now, this can last for several minutes or potentially longer when this is happening repeatedly without the patient waking up. We would call that Statusepilepticus, which we'll look at here in just a moment. But this describes our generalized or tonic-clonic seizure. And usually this is where patients will have a long postictal phase following these types of events, more so than some of the others. Absence seizures, these do not involve any changes in motor activity. Okay, so no seizing, no movement of arms, no movement of legs, nothing like that. No change in your motor activity. It is characterized by a brief lapse of consciousness in which the patient seems to stare and not respond. Okay, so with this, there is no change in motor activity, but maybe the patient's staring out the window or seems to stare at something. They don't go unresponsive. They might still be able to answer your questions, but they are just staring and not really physically responding. Okay, so that's an absence seizure. Now, a partial or a focal seizure, this is where this is called a we have two parts of this, simple and complex. So the simple partial seizure has no change in the patient's level of consciousness, but they may have numbness, weakness, dizziness, visual changes, or unusual smells and taste. And it could cause just a little bit of a twitching or brief paralysis in one extremity or on one side of the body, but there is no change in the level of consciousness. And so that's very important. So I want you to think about the patient still looking at you. They're talking to you normally, but they have repetitive motion in one part of their body, maybe their arm or maybe their hand or maybe their leg, but they're not having an altered level of consciousness. Now, with the complex partial seizure, that is where you see an altered mental status, and this results from abnormal discharges from the temporal lobe of the brain. And again, this could be characterized by lip smacking, eye blinking, or isolated jerking, but they do have an altered mental status, and that could be just confusion or it could be completely unresponsive. These patients may also experience unpleasant smells or visual hallucinations, have uncontrolled fear, or perform repetitive physical behavior. All right, so that's the complex partial seizure. Now, looking at the term aura, Patients may experience an aura prior to a seizure. Not everyone does, and there are several different types. So they might just have a general feeling, meaning they know they're going to experience a seizure, so they get somewhere safe. They might have a certain smell. They might have a taste in their mouth, or some patients report seeing certain colors, like everything around them becomes red or blue, or they see these spots. So there could be a visual change. And sometimes they can have service animals that can sense these changes in the body, even if the patient doesn't. So in that case, the patient is just putting off these vibes that the animal is sensing. And so then the animal would tell them that they are about to have a seizure and they need to get somewhere safe. So that way they can lay down in the floor, or they can get to their car, or they can, stop whatever they're doing and get somewhere safe, so that since they are about to have the seizure. All right, so that's auras. So generalized seizures, like we said, these are characterized by that sudden loss of consciousness, chaotic muscle movement and tone, and usually apnea. So that's one of the scariest parts of this, is that the patient is not breathing during this seizure. And this is generally, as we said, followed by a postictal state. Now the seizure itself might last 3 to 5 minutes, and that's quite a long time to be going without breathing. So we're going to talk about treatment, but what we do need to know is that we don't want to put anything in the patient's mouth. We don't want to forcefully hold them down or anything like that. We could apply oxygen, but the patient's really not breathing on their own, so that oxygen's not going to do a whole lot. But we don't want to hold them down and force ventilation. And that postictal state could last quite a bit longer. And so we'll look at some details of the postictal state here in just a few. That absent seizure, which we said is that just staring out, no loss of consciousness, but no response during that time period, as if they're just staring. This usually lasts for just a few seconds. Formerly, this was called the petit mal seizure, and this is where the patient fully recovers with a brief lapse of memory of the event. And so you might not even notice that this is happening in the patient, because it could last, just 5 seconds of them staring out the window and you not realizing what is happening. And then status epilepticus. Remember, this is where we said that the seizure continues every few minutes without the person regaining consciousness, or if one seizure lasts longer than 30 minutes. So what this means is that the patient was experiencing a generalized seizure. They've got that full-blown tonic-clonic movement, formerly called this a grand mal seizure, and the patient is seizing for 5 minutes, and then they go into a postictal state for 2 minutes, and then they start seizing again, and they seize for 3 minutes, and then they go into a postictal state, but they never wake up. Okay, they don't regain consciousness. They go from seizing to postictal state, or just total seizure with no postictal state, but they don't wake up for around 30 minutes. If this is repetitive, then that's going to be status epilepticus, and that's a really serious problem, because as you can see, the patient is not going to be breathing normally during that time, sometimes even during the postictal state. Now let's look at some common causes of seizures. As we said, epilepsy or epileptic seizures, these are congenital, meaning you're born with this condition. There's nothing really that causes it. They don't know what the deal is, but epilepsy is its own disorder. But there are several other reasons that someone could be experiencing a seizure. So it could be a structural change, like a tumor, and that could be benign or cancerous. It's in the brain. It could be infection of the brain, it could be scar tissues, head traumas, or strokes. So those structural changes inside of the body could cause seizures. Other things that can cause it, and some of these I would argue to say that these are much more common in the patients we would see in the pre-hospital world, are metabolic changes like hypoxia, abnormal blood chemicals, hypoglycemia or low blood sugar, poisoning, drug overdose, and sudden withdrawal from alcohol or medications. And then the last cause is febrile, which is coming from a sudden high fever. And so we're going to get into that in just a little bit as far as treatment for all of these. But what I want you to know specifically about the febrile seizures is that it's not about how high the fever is, it's more about how quickly it got there. Okay, so if you've had a fever for, let's say, 3 days and it goes up to 103 degrees, your body has had time to compensate and make those changes as it's continued to rise over the 3 days. But if you get that same fever, or even a fever of 101, and let's say that jumps up in 30 minutes instead of 3 days. Your body does not have time to make those changes and make that compensation, and that's where you start to see the seizure. So it's not always about how high the fever is. Often it's about how quickly it got there. So just something to consider.